Hi friends, today we are going to discuss about an uncommon topic, prostatic abscess.
Symptoms include acute onset in duration and include increased urinary frequency, urgency, perineal pain, dysuria, hematuria, difficulty in urination or even urinary retention. Risk factors which predispose for prostatic abscess are urological procedures such as prostate biopsies, diabetes, end-stage renal disease, ESRD, patients on hemodialysis, liver cirrhosis, cancer patients receiving chemotherapy, transplant recipients, HIV, AIDS patients, men with inadequately treated benign prostatic hyperplasia, BPH. Diabetes is the most prevalent risk, found in over 50%. Etiopathogenesis, reflux of infected urine into the prostatic ducts during voiding. More risk factors include chronic Foley or suprapubic catheters, neurogenic bladder dysfunction, poorly controlled diabetes, immunosuppressed patients, intermittent self-catheterization, bladder outlet obstruction, underlying voiding dysfunction from neurological diseases, severe benign prostatic hyperplasia, pelvic injury. Organisms include E. coli as the most common causative organism for prostatic infections. Nosocomial infections involve Pseudomonas aeruginosa, Enterococcus, or Staphylococcus aureus. Nosocomial frequently demonstrate increased antibiotic resistance, and are more prone to progress to a prostatic abscess. Epidemiology, overall incidence of prostatic abscess 0.5% of all urologic diseases. The mortality rate is between 1% and 16%. 6% of all acute bacterial prostatitis patients will develop a prostatic abscess. Investigations include complete blood count with differential serum PSA urinalysis, and blood and urine cultures, transrectal prostate ultrasound, CT scan, prostatic MRI. Management. Conservative management is reasonable for abscesses up to 1 cm in diameter. Conservative treatment can be done between 1 cm and 2 cm in diameter, but surgical aspiration and drainage will speed recovery and reduce hospitalization. Non-responders to ultrasound-guided drainage should undergo CT scan or MRI.
Treatment part includes empiric antibiotic therapy should initially be targeted mainly toward gram-negative organisms. Commonly used first-line antibiotics are levofloxacin, renal adjusted dose, broad-spectrum beta-lactam penicillin, or cephalosporin. The addition of an aminoglycoside, tobramycin 5 mg per kilogram daily, in the initial treatment regimen should be considered, depending on the severity of the disease. A minimum 2-week course of antibiotics is required for complete resolution, although 4 weeks is the traditionally recommended duration of medical therapy. Many men require a longer course of treatment, with the average patient receiving slightly over 30 days of medical therapy. Serial imaging should be used to monitor and confirm the complete resolution of the abscess.
When to suspect extended-spectrum beta-lactamase organism, especially in patients who present with febrile urinary tract infections or sepsis after prostatic biopsies. Treated with intravenous carbapenem. Third-generation cephalosporins. Astrian amikacin, are various combinations while awaiting blood and urine culture results. Surgical intervention. About 80% of patients will ultimately require early surgical drainage based on their overall condition or the size of the abscess. Different approaches have been described for ultrasound-guided abscess drainage, namely transrectal drainage, transurethral unroofing, resection, or aspiration, and transperineal evacuation of the abscess. After a single aspiration, the reported recurrence rate ranges from 15 to 33%. About 1/3 of patients will eventually require transurethral prostate resection. Factors which indicate poor prognosis are: age above 65 years presenting temperatures higher than 100.4 F, 38 C, history of urinary retention or symptomatic benign prostatic hyperplasia, chronic Foley catheterization, uncontrolled or poorly controlled diabetes, HIV, AIDS, debilitated general health status, renal failure. Treatment at discharge. Oral antibiotics, usually a fluoroquinolone or trimethoprim sulfamethoxazole based on culture results. Traditional treatment necessitates at least 4 weeks of antibiotics.